This is our patient profile on diabetic neuropathy. Enjoy. Meet Dave. Dave is 54 years old, is married, and works as a general contractor. He was diagnosed with type 2 diabetes a few years ago and ever since has found it a struggle to keep his blood sugars under control. Lately, he has been feeling off and has been experiencing changes in his sensory and motor function, especially in his feet and somewhat in his hands. Poor Dave, this is how he has been feeling. He is in lots of pain that he describes as burning, stabbing, itching, and tingling, especially in his feet, somewhat in his hands. It is accompanied by numbness, making it feel like he is always wearing stockings or gloves. He says his feet are so sensitive it hurts to take a shower or feel cold sheets. His muscles are weak, and he has noticed decreased ankle reflexes. He also complains that his symptoms are much worse at night. So Dave decides to see his doctor. His doctor suspects diabetic neuropathy, progressive nerve damage, based on his history of diabetes, but would like a thorough history and physical exam to confirm it. So she asks Dave about his symptoms and talks to him about other tests she could perform, including nerve conduction testing, sensitivity and sensory testing that are non-invasive, and electromyography. She decides these won't be appropriate and then talks to Dave about the need to control his blood sugars to prevent the progression of the neuropathy. Dave's doctor does her best to describe what is happening inside his body that is causing his symptoms. Although there is no sure cause for neuropathy, there are many theories. Here is one simple theory. His problems controlling his blood sugar leads to sustained hyperglycemia, and all those extra sugar crystals cause a lot of damage inside his vessels, especially the small vessels and capillaries. This leads to decreased endothelial function and eventually decreased perfusion to the surrounding skin and nervous tissue. This will cause ischemia and eventually permanent damage and loss of the surrounding skin and nervous tissue, and can be quite painful. Hyperglycemia can also prevent nerves from transmitting signals and communicating effectively, and this could account for the weakness. There are some complications of neuropathy that are severe, including ulcers, especially on the feet, and amputation. According to our MedSurg textbook, diabetic neuropathy causes over 60% of non-traumatic amputations. It can also affect more than just the periphery. It can affect the eyes, which would be retinopathy, bowel and bladder function, which would be nephropathy, sexual function, sweat glands, and the heart as well. Dave and his doctor come up with a plan to manage his pain with medication. He understands that medication will not reverse or cure his neuropathy, but will help relieve his symptoms. It may even take a combination of medications and, of course, careful foot care. Some of the medications we're going to go over right now include topical agents, tricyclic antidepressants, SSNRIs, and anticonvulsants.
Dave's doctor has several medications that she can prescribe him. The first drug class are topical agents, including lidocaine patches or capsaicin. These medications inhibit nerve impulses from sensory nerves, which blocks the neuropathic pain that you are feeling. These medications are contraindicated in patients with known allergy to the drug, heart block, shock, and decreased plasma esterase. There are some common adverse effects that come along with these topical agents, such as rash, warmth, and irritation at the site of application. These medications can come in a cream, lotion, gel, ointment, and patch form. Remember when applying this medication to not touch the eyes, nose, or mouth to avoid injuring the mucous membrane. If the patient would feel more comfortable using gloves to apply the medication, that can be done as well. Also, make sure to carefully inspect the skin in the area that the medication is about to be applied, because it should not be put on injured or broken skin. After applying the medication, it is important to not wrap the area so that adverse effects are not exacerbated. He can also use tricyclic antidepressants such as amitriptyline. These medications work by blocking the reuptake of serotonin and norepinephrine, which makes more available for pickup by the nerve cells. While this medication is typically used for major depression, they have an unlabeled use for treatment of neuropathic pain. These medications are oral administration and may take 4 to 6 weeks to start seeing a therapeutic effect. They are contraindicated for patients who are allergic to the drug, who have had a recent myocardial infarction, myelography, and in pregnancy and lactation. Common adverse effects that are seen with tricyclic antidepressants include dizziness, drowsiness, orthostatic hypotension, ECG changes, constipation or diarrhea, and dry mouth. There is a black box warning for children and young adults when taking this medication that it may cause them to have suicidal tendencies, so mental status needs to be assessed frequently. When changing positions, the patient needs to move slowly to decrease the risk of fall if orthostatic hypotension is experienced. When using these drugs, the patient should not consume alcohol or use any other CNS depressants because it will cause further depression of the central nervous system. It is also important to not abruptly discontinue this medication because it can cause withdrawal symptoms to occur. The patient should also be educated on the signs and symptoms of serotonin syndrome, such as confusion, agitation, hyperreflexia, and coma. Here's just another reminder with a picture of the different adverse effects of tricyclic antidepressants.
Another drug class that would be a second line of treatment for Dave are SSNRIs, or selective serotonin and norepinephrine reuptake inhibitors. An example of this would be duloxetine or Cymbalta, and this was actually the first FDA-approved medication for the treatment of diabetic peripheral neuropathy. It works by inhibiting the reuptake of serotonin and norepinephrine, just like tricyclic antidepressants. It is contraindicated in patients with impaired renal or liver function, closed-angle glaucoma, and with alcohol intoxication. Side effects are very similar to those of tricyclic antidepressants, but are generally more tolerable. These again include some GI effects, sedation, dry mouth, drowsiness, weight gain, and urinary retention. Because this is also used as an antidepressant, it's important to monitor for suicidal thoughts and to not discontinue the drug abruptly. It's also important to teach the patient not to combine this medication with alcohol or other CNS depressants that could increase sedation and drowsiness. And again, here's a visual and a reiteration of the adverse effects of SSNRIs.
Here's more information on serotonin syndrome. Please refer to the graphic for signs and symptoms.
Anticonvulsants can also be used to treat diabetic neuropathy. Two examples are gabapentin and pregabalin. The action of these drugs are thought to decrease cell activity and release of neurotransmitters like norepinephrine by binding to calcium channels and act like GABA. Adverse effects include CNS depression, like we have discussed with other medications. Patients may experience ataxia, increased suicidal thoughts, and hepatotoxicity as well. Patients should know not to take with alcohol or other CNS depressants. Renal and liver function should be monitored as well as neuropathic pain. These drugs should not be discontinued abruptly and may take several weeks to take effect. Pregabalin has also been known to cause infertility in men who wish to have kids, and neither drug should be used in pregnancy or lactation. And here's another visual reminder of the adverse effects of anticonvulsants. Let's get an update on our patient Dave. It took some trial and error, adjusting dosages and frequent monitoring, but Dave is now experiencing some relief of his symptoms. His doctor explained that some of the medication takes weeks to help reduce symptoms and it may not completely relieve his pain. He has remained free from many complications of neuropathy and is committed to controlling those blood sugars.
Okay, now we have a couple of NCLEX questions to test your knowledge. Here is question number 1. Amitriptyline, or Elavil, is prescribed for a diabetic patient with peripheral neuropathy who has burning foot pain occurring mostly at night. Which information should the nurse include when teaching the patient about the new medication? Take a second to look at all of the answers. Right, if you answered A, you are correct. Amitriptyline will help prevent the transmission of pain impulses to the brain. Tricyclic antidepressants decrease this transmission to the spinal cord and also improve sleep quality and are used for depression, but that is not the major purpose for their use in diabetic neuropathy.
Question number 2 is, a patient with type 2 diabetes has sensory neuropathy of the feet and legs and peripheral vascular disease evidenced by decreased peripheral pulses. The nurse teaches the patient that. The correct answer for this question is B. Flat-soled leather shoes are the best choice to protect the feet from injury. The nurse should teach the patient to avoid high heels and that leather shoes are preferred. Other important teaching points to know is that the feet should be washed but not soaked in warm water daily. Also, heating pad use should be avoided. And for our last question, a client with diabetic neuropathy reports a burning electrical type pain in the lower extremities that is not responding to NSAIDs. You anticipate that the physician will order which adjuvant medication for this type of pain. The correct answer is lidocaine patch or capsaicin. These are topical treatments to relieve some of the burning pain in the legs and feet. The patient must be taught to monitor the skin for adverse reactions and not to cover or wrap after applying to control the absorption.